okay? Yeah. There we go. Good. We're good. I think we're about. Yeah. All right, everybody. Thank you so much for coming. Give yourselves a round of applause for making it here today. Everyone here tonight we're assuming that you have a friend or a family member that is afflicted with IBD and is going through all the challenges involved with that. And it's really nice to see that you care about your friend to come out here to help support them. So thank you very much for coming. Before we begin, they asked, first of all, I'm the host, Mendy Pellin. I have ulcerative colitis for about 20 years, and I'm here to share my story. And the goal of sharing my story is that you might see your story and my story, and maybe you'll feel like, you know what, I'm not the only one that goes through this. So I decided, because we are all on the same page, or a lot of us are on the same page, I'm going to speak in IBDs. I'll tell my story in IBDs. Acetylcholine, Colazole, Canasta, Rawasa, 6-MP, Prednisone, Oxycodone, Remicade, Entyvio, Humira, Kinanahara, Tacrolimus, Xeljanz, Tofacitinib, herb tea from China, Nambrodipod, allergy elimination therapy, holistic healers, gluten-free diets, God shell diets, and now I'm here. Yes, we've all been through a lot, from being diagnosed to going through a lot of challenges, and I was diagnosed when I was 21 years old, and of course, I was a young man, and like a lot of young men, we ignore this kind of stuff. You know, we're just like, okay, you know what? It'll just get better by itself, or it'll kill me, whatever. You know, there's nothing I can do about it. And of course, it was kind of like one of those annoying phone calls that kept on coming in. It was like my body was ringing, and it kept on getting louder and louder, and the volume kept on getting louder, and the ringtones kept on getting more annoying, and I kept on pushing ignore until I just put it on silent. But it always catches up with you, and I had a full-on, a major flare-up, and you know, I went through the ASAs, and that didn't really help. I went through some other things, and then of course I went through prednisone, and I had to get 2 hip surgeries thanks to that. I'm not to put prednisone down, because if you need it, the doctors will tell you it could be a miracle for some people. So I don't want to put anything down. And with that said, I just want to start off with a disclaimer I forgot to say, that tonight here you'll be hearing from different people that are walking around here. Some of you have Crohn's, some of you have colitis, and sometimes someone is in remission, and they call it the cure. And then they feel like they have to tell everyone that they found the cure. And there's nothing more annoying than that. And you could even look at the comments of COL for this event. People were like, I really hope that they are going to talk about diet over here, because that is the cure. It's all about the diet. I really hope they're going to talk about this or talk about that, because, and the last event, this is how this all started. We started with a support group, which you could all sign up for. This all started when I posted about the event, and then somebody asked me, hey, are you going to talk about the carnivore diet at this event? And I'm like, I don't plan on talking about the carnivore diet, but if you want to come, you could come talk about the carnivore diet. So he went on his status and started telling people not to come to the event because it's a waste of time. Because if you really want to know the cure, contact me. I know the cure. And so I asked him, this could be the cure for somebody at a certain period of time, which is called remission. And by telling people that you found a cure, you're giving some false hope, and you're creating these unnecessary anxieties, which could lead to a flare-up, and it's that cycle. And he's like, no, I'm telling you, I spoke to this lady in Crown Heights. She tried it. It was a cure. And I said, what do you have? Ulcerative colitis, Crohn's? He's like, oh, no, I don't have anything. I just know. So there's a lot of people that are out there that know, and I think it's important that whenever you speak to someone and you hear their story, just know that this is working for them right now. There's another guy that kept on coming over to me on Kingston Avenue, putting his arm around me and like, Mendy, are you still taking medication? And I said, yeah. He's like, I'm telling you, you're putting poison in your body. You're slowly killing yourself. You gotta stop. I'm telling you, there's diets, there's certain natural remedies I could give you. And he kept on going on and on. A few years later, I saw him. He looked really, really, really not so good. And he wound up having a big flare-up and had emergency surgery. And then he wasn't talking about stopping medication. So, again, whenever you hear someone's story, please just take that with a grain of salt. And also, for the families, there are families here that they mean really well, and you want to help your loved one. It's better if you kind of try to wait for them to help you, to ask you for the help, instead of asking, are you sure you can eat that? Is that okay if and then when you read different things about different cures, coming over to them and saying, listen, I know this is really bothering you, but there's a cure out there if you eat a bunch of roses every day for about 3 years, that's the cure. So, yeah. Where was I going with this? So anyway, my story, long story short, my colitis was out of control, and finally, my GI told me that he wants to cut out my colon, and I followed my gut, and I moved to California. I was just like, let me just change the setting and ignore this guy. 2 weeks after that, I was in remission. And then after 2 years in California, I had a flare-up for many years, and I know all the bathrooms everywhere and which ones are for, employees only. I've been an employee many times at a lot of stores. They didn't know about it. I went in there, where's your bathroom? Oh, employees only. Okay, I work here. Yeah, I'm just going to go. I've been in many ladies' rooms because that was the only one available at the time. Please try not to judge me. And usually when I walk out of the stall in the ladies' room, I use the same line always, and I ask them, well, what are you guys doing in the men's room? You know, you got to mix it up a little bit. You got to mix it up. So there's definitely, in my experience, there's definitely a mind-gut connection, because there are things that I did in my journey that's the only thing that could explain it. And there's definitely medication that has helped me. And there's definitely different treatments. So tonight we have a really nice balance, The only person we're missing is RFK Jr., which couldn't make it tonight. But we have an amazing lineup here, and we really hope that you take some notes. And a big part of tonight is also to, when we're done, speak with each other. You know, we have a community. You're not going through this alone. We're in it together. And thank God for the last few years, I've been in remission, and I'm still here. A lot of times people come to these support groups only when they're in a major flare-up and it's emergency, but I think it's important that even when you're in remission, to come help the people that are still struggling. And so without further ado, I would like to first start this evening with a hero among us in our community. Wherever I go, whenever I speak, I always have to have my PCP say a few words. It's just part of the rules. I don't make this stuff up. So without further ado, please welcome the one, the only, Dr. Rosen.
Thank you, Mandy. Welcome, everybody. A beautiful turnout. Dr. Hoodisman, who'll talk to us later, treats many patients of mine. Dr. Kiefer, thank you for coming. Her interest is in mental, psychological, emotional aspects of the illness. I am no expert in the illness, but I am somewhat an expert in taking care of people. I ran to give you an idea of how extensive the problem is, I ran a quick search through our numbers today. At the ODA, we have approximately 15,000 registered adult patients. And I just ran colitis, Crohn's, ulcerative colitis, terminal ileitis, proctitis, whatever ICD-9 codes I could come up with. Of that number, about 600 have that diagnosis on their charts somewhere. So if you break it down, that's close to 4 or 5%. Nationally, the figures are about 1%, 1.2%, I believe, in the general population, less amongst blacks, less amongst Hispanics. But we are a very fortunate group, Ashkenazi Jews, most of us. And for multiple reasons, we have a rather closed genetic pool, and so we are about 4 or 5 times more likely to get inflammatory bowel disease than the population at large. And that's pretty much what the number looks like. It's 4 or 5%. Well, that's a lot, 4 or 5%. Pediatrics, it is a pediatric disease as well. And Dr. Hoodisman just informed me that they are going to upgrade the pediatric inflammatory bowel disease program at NYU, which I'm very happy about, being an NYU physician. We have approximately 10,000 patients, pediatric patients under the age of 21, and 40 of them have the diagnosis. So that's about 0.5%. which is, I suppose, in line with what we all expect. But that's still a lot of kids, more than we expect. So it's a real problem. And it doesn't really go away. Let's talk to the genetics for a moment, because this is a question I get almost every day. I'm making a shidduch, and they read me such and such a shidduch, and the father has Crohn's, or the mother has ulcerative colitis, or whatever it is, and should I go ahead with a shidduch? What's the genetics of it? The genetics of it are very complicated. It's not generally monogenetic. It's not hemophilia. But it does run in families, as you all know. If you suffer, you're likely to have someone in your family, close or further, with the disease. So it does run in families. And as Mendy pointed out, it doesn't really go away. So I generally have one answer for people who call me about the shidduch. It's a peckle. It's a peckle. It's real. You have to take care of yourself. You'll be involved with, more than likely, you'll be involved with doctors for the rest of your life, in one way or another. But hopefully you can live a long, happy, healthy life if you take care of yourself. So, like many of the other peklach, that everybody seems to have a peckle, we just don't know about them. Generally, the answer is to go ahead with it as long as you realize that it is a peckle. Lastly, before I hand over to Dr. Hudesman, when you look at people who sleep more, stress less, exercise more, they tend to have less inflammatory bowel disease. So, as a general rule, when we don't fully understand the causes of illness, when we don't fully understand the cures of illness, it's always a good rule to take care of oneself, to sleep more, stress less, exercise more, and eat well. I agree with Mendy. There is no magic cure diet. Some of my patients have done well with a specific carbohydrate diet. There are 100 diets out there, I'm sure. If I have one piece of dietary advice, stay away from the bakery. Trans fats, high sugar, high gluten, stay away from the bakery. You can probably experiment elsewhere, but the bakery is no place to experiment. And in closing, the Rebbe's words, Trach gut wird sein gut. A positive attitude helps everything. And it really helps. It's not just out there. The Rebbe said something nice for us to think about. Trach gut wird sein gut. I deal with people every single day who are not well. The people who have the right attitude, who approach their disease, and I'm sure Dr. Kiefer will talk more to this point, the people who approach their disease with a positive attitude generally fare much better. So I think that's good advice for all of us, for those of us who don't have IBD, and for those of us who are completely healthy. Eat well, sleep a little more, exercise, and have a positive attitude. Dr. Hudesman.
All right, thanks for the invite. Very happy to be here. So I was asked to give an overview of IBD. So there's a lot to talk about. So I'm going to try to touch on a couple of key topics and sort of talk about what I say to my patients in the office, and I know we're going to have plenty of time to go into more details, right? Because as we've heard already, every case is a little bit different. So I'm going to touch on sort of the general, why do people get IBD? Talk a little bit about the diagnosis. I have some pictures in there, so if you're a little squeamish, you might not want to look, but I think it's helpful to actually look. We say inflammation, what does that really mean? Talk about generally what are our goals of therapy, right? And our goals of therapy, that means whether you're on medications, whether you're on a biologic, whether you're just doing diet, the goals are the same. Talk about our different options, what's coming, and again, we'll have plenty of time for Q&A. These are just some disclosures. Okay, so what causes IBD? So the way I like to discuss with my patients is, as we just heard from Dr. Rosen, everybody's genetically predisposed, right? But it's not like if your parents have it, you have a 50-50 shot of getting it. They found to date over 200 different genes associated with either Crohn's or ulcerative colitis. So although it's more common to have IBD if your parents have it, most of my patients do not have a family history, right? The next thing you need is some type of trigger in the environment to set it off. And what that means is our gut bacteria has trillions of bacteria, right? And it could shift based on diet, medication, infections, all sorts of things. And when the bacteria changes, because of your genetics, you could have this abnormal immune response. So what does that really mean practically? So I use this as an example, and a lot of time, just so that people are like, well, what's my trigger? A lot of times we don't know what a particular patient's trigger is. But the way I like to explain it is, let's say you're out to dinner with some friends, some family, everybody eats something bad, you pick up some infection, everybody has pain and diarrhea, everybody gets better but you or but that patient, right? If I went out to eat, I picked up norovirus, which is going around, I start having pain and diarrhea, my body would sense something was wrong. It would send a bunch of cells there to create inflammation to get rid of the problem, which is a good thing. When my body senses the problem's gone, it shuts off, it cools down. With Crohn's and ulcerative colitis, once your body starts attacking, it doesn't stop. Your body keeps attacking itself and keeps attacking itself. And how severe that is just everybody's personal genetics and triggers, right? So that's the general understanding. So how do we diagnose ulcerative colitis and Crohn's? So first, we want to obviously talk to our patients and get a good history. So ulcerative colitis classically, right, there's always some nuance, but classically you'll have bleeding and you'll have diarrhea, right? Other things that you might hear is urgency, right, where you have to get up right now and run outside. You can't hold it, right, to go to the bathroom. Some people with ulcerative colitis sometimes feel, they say they're constipated. This is the concept of tenesmus, meaning that they're not fully evacuating. So you might go to the bathroom, you come back, 5 minutes later you have to go again. And then you could have pain and fever and weight loss, which you could see with many different diseases. Crohn's could be a little bit different. And what I also like to talk to my patients about when I first talk about both Crohn's and ulcerative colitis is how you feel does not correlate always or go along with what's happening on the inside. So you may feel perfect, right? And I could do a colonoscopy or a CAT scan at that given time, and I could see a lot of inflammation. Now, the opposite is true as well. You could have a lot of stress, eating very poorly, feel really sick, and I could look inside and everything's great, right? So that's what makes things a little more complicated. So with Crohn's, some people could have some inflammatory symptoms like I just mentioned, like diarrhea and abdominal pain. Other people could have something called an obstruction, where their intestines narrow, or in other terms, a stricture. So you might be feeling fine, you might have a large vegetable meal, and all of a sudden your intestines get plugged up, like plugging up a pipe, and you vomit. Some people could have fistula. Fistula is just a connection. So if I draw a straight line, you might have heard these terms, a straight line between my two hands. That's just a fistula between my two hands. So you could have a connection from one part of the intestine to the other. That might progress and get worse, but you could feel fine that whole time. So there's a variety of presentations. Also, it's very important to ask about these extraintestinal manifestations. So I have a handful of patients every year that initially present without your typical GI symptoms. They could just have some joint pains or swelling. They could have certain types of skin rashes, some sores in their mouth, or there's some eye pain. So it's always very important to talk to your doctor about all of your symptoms even if you might not think it's related to Crohn's or ulcerative colitis. Let us tell you don't worry about it, right? But it's important you let us know. Because again, I just saw somebody a couple weeks ago, maybe a little bit of pain, but the real reason they came in was their ankles were swollen and they were a runner, they run 5Ks, and they couldn't run anymore with a little bit of stomach pain. And they've been bouncing around to different rheumatologists and orthopedic surgeons, and she had Crohn's disease. We do a bunch of different labs that we want to check. It's important to check, where the doctors, including myself, could be a little bit annoying, checking all the different blood work. But what we're really looking for in the blood is, are there markers of inflammation? Is somebody anemic, right? Are their vitamin levels low? These could all be different signs of Crohn's and ulcerative colitis. Now I'm going to show some pictures. You don't have to look if you'd rather not, but this is what a normal colon looks like, right? So when we're doing a colonoscopy, right? All right, so this is what you see here. It's pink-ish, and you see those lines, those red lines, those are normal blood vessels, right? So this is normal, and this little bump right here, this is a polyp. So when you hear somebody has a polyp removed, that's what you're seeing there. Now, when people with ulcerative colitis and Crohn's disease, and I'm going to first show some pictures of ulcerative colitis, there's different levels of severity. And again, it could look really bad, and somebody could feel fine, right? So it's important to put everything together. So this is mild inflammation, right? You don't really see the blood vessels like you do there, right? But it doesn't look so bad. This looks a little angrier, a little redder, a little more mucus, right? And this looks a lot worse, right? And that's some blood in there, right? So it could vary on the severity. Now, people with Crohn's disease can happen anywhere from your mouth down to your anus, so in your stomach, in your esophagus, which is less common, but we see it, in your small intestine and colon, which is the most common places to see it, whereas ulcerative colitis could only be seen in the colon. So this is just the small intestine here. This is the ileum. I don't know if you can make this out. You see sort of these, it almost looks like a fluffy pillow or these finger-like projections. We absorb all of our nutrients in the small intestine. So this is normal. And then you could see here, maybe not as fluffy, and you see these little white spots, which are ulcers. And then here, you could see these deeper, right? It's almost like somebody took a rake to that small intestine. These are deeper ulcers. Now, this patient felt fine, felt great, right? Was on a diet, didn't have pain, but this doesn't look good, right? This is just a matter of time before this progresses. And then this is just a narrowing or a stricture, right? You could see how open this one was, and this is now like a pinhole. Okay. I'm going to just go through this. We also like to use different imaging studies. So we'll do CAT scans and MRIs. Usually in our younger patients, especially patients less than 50, we like to do an MRI to minimize radiation exposure. Really, you can get multiple CAT scans. If you're getting more than 20 or 30 CAT scans, that's probably not a good thing. But again, in our younger patients, especially if we're going to have them over time, we prefer an MRI. We also do these CAT scans, and what we're looking for here is different bowel inflammation. So I just want to jump to the goals of therapy, and for me, I think this is very, very important. And again, I said this in the beginning, this does not matter if you're not taking any medication, if you're taking an infusion, injection, if you're combining therapies, if you're just on a diet. The goals should be the same, right? So what are our goals? First, we want to make the diagnosis quickly and accurately, right? And we want to include the element of prognosis, meaning what do I think is going to happen 6 months from now, a year from now, 5 years from now. We want the patient to feel better, right? We want them to have normal bowel function, no abdominal pain. We also want to improve their quality of life. And I know we're going to hear from Dr. Kiefer, this doesn't always correlate or go along with your bowel function. So I have many patients that I repeat a colonoscopy or an imaging study or their lab work and everything looks great, but their quality of life isn't there, right? And whether that's fatigue, whether that's anxiety, whether that's chronic pain. So although it's under sort of the normal bowel function, that's something that we have to think of just as important as the symptoms driven by inflammation. We obviously want to induce remission rapidly. What does that mean? Get you better quickly. We heard about steroids. Yes, I agree. Sometimes it's a necessary evil, but the goal is to be in remission off of steroids. And really, with all of this, what's our ultimate goal? Is we want to modify the outcome, right? We want to modify your disease course. So you're not going to the hospital. So you're not needing surgery if you don't need it. That we're eliminating disability, right? That you have a great quality of life. And that's the ultimate goal with all of this. So this is just another way to look at it. So this concept of our goals of care really we started talking about something about treat to target. Because when I was first in training, all we really talked about is you feel sick, let's give you some medications. Once you feel better, you're okay, come back when you feel sick again. And we realized if we did that, we're not really changing the course. We're not changing your long-term prognosis, how you're going to feel, your quality of life. So why is this important? If you just look at the natural history of Crohn's disease, when people present, over 85% have an inflammatory type. What does that mean? There's swelling and inflammation, they could have pain and diarrhea, right? But if you do not put patients on appropriate treatment, and we could discuss what that means, and that varies from patient to patient, but if you're not on appropriate treatment, 10 years later, 15 years later, 20 years later, over 88% of patients now will develop a complication, meaning your intestines will narrow, right? You could develop an abscess or a pocket of infection or pus on the inside. What about surgery? Within the first year of diagnosis, about 10 to 15% of patients with Crohn's will require surgery. But if you do not treat this appropriately, you follow these patients out 10, 15, 20 years, over 2/3 of patients will need surgery. So what do we think is happening here? So the black line here are your symptoms, right? So most people, it goes up and down. There's periods of time where you're feeling good. There's periods of time where you're not. However, the purple line here is sort of your bowel damage and what's happening with the inflammation. So although symptoms could fluctuate and go up and down, if we're not healing you on the inside, if we're not improving what's happening on the inside, you're slowly building up damage, right? And then your intestines narrow, and that continues, and then you need surgery. And this is one slide that I always like to show in any of my talks, right? Just very basically, the y-axis here is something called CDAI, it's symptoms. It's just how we grade somebody based on how they're feeling. The x-axis here is what the colonoscopy looks like. And what you could see is that the dots are all over the place. So again, you could feel great, the colonoscopy could look horrible. You could feel really sick, and the colonoscopy look great. So symptoms, although are extremely important and quality of life is important, it's not enough for us to help guide or choose treatment. It's also important to realize that ulcerative colitis may progress as well. If we don't treat ulcerative colitis, you could get precancerous change called dysplasia or develop a cancer. And up to 30%, if not more, of our patients with ulcerative colitis may require surgery where the whole colon has to come out. You can get something called the J-pouch. And that's, again, if it's not adequately treated, or some patients, even when adequately treated with severe disease, still may require surgery. And with surgery, you could still live a very high quality of life. So again, just to sort of summarize why this early treatment is important, right? So again, this is what I showed before. Symptoms are up and down. But if we wait till when you're here, where you're developing these complications to start treatment, it's already too late. There's already too much damage on the inside. Versus if we're able to treat early on, we could hopefully flatten this curve and prevent damage to your intestine long term. And this is just another way to look at it. I'm going to skip through that. And these are sort of our guidelines. We call them their STRIDE 2 guidelines on how we treat a patient, right? So whatever therapy we start you on, right, doesn't matter what the therapy is, we're going to monitor symptoms, obviously, initially. We're going to want them to feel better. Then within those first 4 to 6 weeks, we're also going to repeat some blood work. If you're anemic, or is your anemia getting better? If your inflammatory marker, if you're familiar with something called a CRP or an ESR in the blood, is that getting better, right? Then around 3 or 4 months, we're checking some stool tests. We're doing something called intestinal ultrasound now, just to say something objective to show that the bowel's getting better. And then usually at about 6 months after treatment, we repeat a colonoscopy, and everybody gets mad at me. Why do we have to do it again, right? But it's important for us, if the goal of treatment, if I'm putting you on something, the goal of treatment is to heal you, I want to prove that you're healed. Once we hit that target, it's not like I'm doing colonoscopies every time you come to the office, right? But if we don't hit that target, then we may need to change course. Maybe our my initial choice of therapy is the wrong choice and we need to move things. So the idea is we really need to closely monitor patients where symptoms are extremely important, but it's not enough. And again, now we have things from blood to stool tests to ultrasounds you could do in the office to colonoscopies and CAT scans and so forth. Also very important to talk about just general monitoring and prevention. Having long-standing inflammation, right, going on certain medications could increase your risk for other things. So vaccines, it's important to talk about certain vaccines, right? So we heard about tofacitinib or Xeljanz earlier. It's something called the JAK inhibitor. That known increases the risk for shingles. It's not too fun to get shingles, so we could prevent that from vaccinate you with the shingles vaccine, right? Certain medications will recommend the pneumonia vaccine. Bone health is very important. Having inflammation could lead to sort of bone breakdown, something called osteopenia or osteoporosis. Being on steroids for more than 3 months, even just 10 milligrams of prednisone for more than 3 months, could increase your risk for osteoporosis. So your doctor should be ordering a bone density, right? Should you be on calcium and vitamin D? Cancer prevention, extremely important. Another reason why we do colonoscopies, to look for any of those polyps you saw in the picture or other precancerous change. Skin cancer, we do see an increased incidence in skin cancer, even though it's small, but we do see it with a lot of our patients on certain biologic therapies. So seeing a dermatologist once a year for a full body screening is extremely important. Seeing your gynecologist for pap smears. Smoking is probably the worst thing, and anybody that sees me, they know I'll be lax on certain things, have an extra glass of wine, that's okay. Cigarettes are probably the worst thing you could do for Crohn's disease. Just a side note, you might hear people come in with ulcerative colitis. There is this concept where patients with known ulcerative colitis that are smokers that stop smoking, their ulcerative colitis symptoms may worsen, okay? And then they start smoking and they feel better. We still don't recommend cigarettes. It doesn't mean that you're healing on the inside, but you'll hear that as well. But starting smoking isn't going to make your ulcerative colitis better, and ulcerative colitis is the worst thing you could do for Crohn's, more likely to get surgery, less likely that your medication is going to work. We're going to talk about depression and anxiety, but sort of just talking about that and just how it's affecting your life. Are you spending time with friends and family? Right? Are you just sitting at home? Are you missing days of work or days of school? So all of these are important questions to ask. And therapy-related testing just means certain therapies we need to monitor different blood work. Okay, so I'm just going to summarize some therapies just in general. There's so many different therapies. I could speak just an hour on that, and I think that's going to be better to discuss in a Q&A, right? We heard a little bit about diet. What I would say is there's no perfect diet for Crohn's and ulcerative colitis. In general, we talk a lot about the Mediterranean diet. We heard a little about the specific carbohydrate before. There's something called the Crohn's exclusionary diet. But for most patients, diet alone isn't enough. Do I have some patients just with diet? Yes, right? And just in the same thing, sometimes for most patients, medication's not enough, right? You need to sort of work together with both these things to get through. I don't have the mesalamines or the 5 ASAs. These are things like Lialda, Prizo, Canasta, sulfasalazine. If you're familiar, they're for mild to moderate ulcerative colitis. They work topically. I didn't list it here, but I just wanted to show you how many different biologic and small molecule or immunosuppressive agents, and I'm happy to go through what that means in the Q&A, there are. If you looked at this 10 years ago, we'd have 3. Right? So this has really exploded. And just in the past 3 years, we have so many different options. And this is a great thing, right? That we have so many different options for our patients now, and we could help select the right medication for that particular patient. The general concept with these agents is, as I said, with Crohn's and ulcerative colitis, your body attacks your own intestine. So what these therapies are doing are preventing your body from attacking your own intestine, which is a good thing. What people get concerned about, understandably so, what the risks are. And the risk could be that it could prevent your body from attacking things that it should, right? Saying that, I come from a place, all of these therapies are safe, right? They're relative, some have more side effects than others, but these are all very safe medications with low side effects. And when you're trying to decide, should you go on therapy, what therapy, you also have to think about what's the risk of not going on therapy. And I think that's what's a lot of times missed in the discussion. Yes, can I put you on an agent that has a small increased risk of infection? Sure. But what's the risk if you don't go on that therapy and we know that therapy is going to work for you? That risk of hospitalization, missing days of school or work, need for surgery is much higher than this small risk where maybe you got a cold and you can't go to school for a couple days, right? But it's very uncommon for us to stop these agents because of these side effects, right? A lot of times we're able to deal with them. And the other nice things is we have certain therapies now that are more targeted for the intestine, right? That sort of really focused right there. And then we have therapies that are less targeted, which might be important in people with bad joint pains, right? Or bad skin rashes, because we want something to cover everything. So what do I choose? So again, these are if I'm going to start on a therapy for moderate to severe ulcerative colitis. So this is somebody that sort of maybe failed mesalamines, the disease is more severe. Usually we're starting therapies that are more targeted for the intestine. But even though I said all of these therapies are safe, why not start with the safest, right? So if they're very targeted, you're going to have very low infection rates. You're not going to have any cancer side effects. Really, the ones I listed here, the biggest risk is whether it's going to work or not, right? Because none of these therapies work 100% of the time. So something like vedolizumab or Entyvio, something like Stelara, ustekinumab, Tremfya, Skyrizi, Omvo, Velsipity. I don't know, you might be familiar, but these are all extremely safe targeted therapies. Now, if you have more severe disease, if you go remember that picture I showed, if I put you on one of those more targeted therapies, it's not going to work, right? It's just not going to work. So that's when we talk about other therapies like infliximab or Remicade, or upadacitinib or Rinvoq, or tofacitinib or Xeljanz. And then if you just at the bottom, spondyloarthropathy, psoriasis, eczema, and the point here is that, again, people with Crohn's and ulcerative colitis could have symptoms outside their GI tract. So if you have a lot of joint pains, I'm not going to use something like Entyvio or something that's more targeted for your intestine. I'll use something that's less targeted. Pregnancy, always a big discussion. Bottom line, all of our biologics, so that means our infusions and injections are completely safe during pregnancy. We do not stop, we do not hold. They're completely safe during breastfeeding. Our small molecules, which are our pills, something like Rinvoq or Xeljanz or Velsipity, we recommend not getting pregnant on them. There's potential downsides, and this has been on animal studies, doses 5, 10, 20 times higher than what we use in humans, saying that in certain situations, our patients will stay on Rinvoq during pregnancy. But again, we try to avoid it. It's sort of similar for Crohn's. I just wanted to touch on surgery. I'm almost finished. So surgery also, yes, although I said we try to avoid it, sometimes it makes the most sense to do surgery first line. And I know every time I say that to any patient, they look at me like I'm crazy and they're trying to run out of the office. But with Crohn's disease specifically, right, there's two concepts. There's inflammation, right, which the pictures I showed, and that's what all the therapies I just showed you treat, is inflammation. And then there's something called fibrosis. Fibrosis is like scar tissue. It's irreversible damage to your intestine. So you could imagine if you've had disease for 5 years or 10 years or 15 years or didn't even know you had it, all that inflammation over time sort of scars down and you have scar tissue inside you. So why am I going to put you on all of these medications, right, where it's not really the inflammation that's driving it, it's the scar tissue. So this is just a study showing going right to surgery for Crohn's versus medication. And in this one study, this was done in a Danish population in Europe. But if you went right to surgery, you were much less likely to be on any of these biologics or immunosuppressive therapies down the road if you did surgery first. I'm not saying we recommend surgery first line for everybody, but it's not for certain patients. It makes the most sense to maybe do that first and reset you and remove the disease. And then I just wanted to, I'm not going to go into the details, but this is probably the newest, this is in clinical trials now. This has been getting a lot of press, and if the phase 3 data looks similar to the phase 2, this will probably be our newest mechanism of action. This is 2-3 years away, but it's something called an anti-TL1A therapy. So it's a newer biologic for both Crohn's and ulcerative colitis. We're doing clinical trials at NYU. Many institutions across the city are doing these trials. I think it's another really good option for our patients, and it's important to have these clinical trials. Okay, so what are the takeaways? So first, it's important when treating a patient with Crohn's and ulcerative colitis to identify the appropriate target, right? Not every patient will have the same goal, right? Maybe somebody that's 17 or 18 with severe inflammation has a very different goal than somebody that's 65 or 70, right? So what's the target? What's the goal for that particular patient? What's the goal for the doctor? And how do we work together to sort of achieve both of our goals? Once we know what those goals are, we want to put you on whatever treatment that is to get you to that goal. But the important thing is we need to monitor you. So symptoms aren't enough. As I mentioned, blood tests, stool tests, ultrasound, colonoscopies, imaging. Again, symptoms are important, but not enough. And the close monitoring is key. These are just a summary. I know hopefully you'll get all the slides on sort of how I approach the different therapies. But again, we have our more targeted therapies that we use for more moderate disease, moderate to severe. And when somebody has more severe disease, that's when we lean on something called infliximab or Remicade, upadacitinib or Rinvoq. And again, remember, whether targeted or not depends on whether you have joint pains. So thanks for your time, and I know we'll have plenty of time for questions.
Thank you very much. For those that have come for the bar mitzvah, it's next door. I know some people saw some of the slides over here, and they were like, this is not what I signed up for. Thank you very much, Dr. Hoodisman. Thank you very much. Really appreciate it. Our next speaker, I'm just moving it to the center because the mechitza is blocking. There we go. We want more people to be able to see you. All right, so we talked about a lot of the technicals, the tofacitinibs and the Xelgens and the biologics and stuff. We're going to move our way up to the mind and body connection here. And so we're very honored here to have with us the director of psychobehavioral research at Mount Sinai's IBD Center and a friend of mine, Dr. Lori Kiefer.
Thank you very much. Thanks so much for having me. I'm really excited to be here to talk about a topic I'm very passionate about. I guess the microphone is too. Okay, perfect. Everyone can hear me now? Yeah, okay. I brought a friend. This is Connie. I'm going to talk about Connie in a minute. Does anyone know what kind of a monkey Connie is before I start? Okay, so this is my favorite way to start out a talk. Connie is a cotton top tamarin. Cotton top tamarins, like Ashkenazi Jews, are at increased genetic risk for developing ulcerative colitis. However, they only develop ulcerative colitis when they are put in captivity by people. And there have been studies in the 1950s when you could kind of get away with this type of research, where they would put these nice little cotton top tamarins, who are about a foot tall, live in Colombia, in the mountains. They would bring them to Ohio or North Carolina, where a lot of these research studies were done, and they would put them in cages with one friend. So two cotton top tamarins in one cage, and they would sort of watch what happens to them. And sure enough, they would go and develop ulcerative colitis. They'd have rectal bleeding, they'd have diarrhea, they stopped eating, kind of got depressed, and they never really recovered. Well, of course, our scientists might have said, maybe it's the fact that we, kidnapped them and took them out of their natural habitat, and they're just stressed out, and that's causing their diarrhea and rectal bleeding because they are genetically predisposed. Some people say, well, maybe it's the diet that you feed these animals when they're in captivity. I'm sure they eat nicer food when they're out in their natural habitat and not what the scientists want to give them. Some people said, well, maybe it's the altitude because, in Colombia in the mountains, it's really high up there, and now you're asking them to breathe the air down here, not only in the U.S., but in a laboratory. So for many years, they tried to understand why it was that when they returned these cotton-top tamarins back to their communities, to their natural habitats, their ulcerative colitis went into remission. Now, because we did all of these, they did all of these studies, right, trying to really understand what was going on. One of the things that happened was that the scientists failed to realize that cotton-top tamarins actually live not in groups of 2 in their cages as we had them. They live in groups of 3. And so the reason that even though they were held in captivity, they developed ulcerative colitis, and they never recovered from that wasn't because they never adjusted to their new diet. It wasn't because they didn't, adjust to the altitude. It wasn't even because they didn't adjust to the stress of having their disease. It's because they were missing a tamarin. They were missing a friend. They were missing their social structure. And that lack of community in those cages was what kept them, not what caused their symptoms, but what kept them from fully recovering. And so I like that story a lot. It's not a well-known story, but I think it really applies here when we're talking about managing an inflammatory bowel disease, right? Who are our tamarins? Who are the people that are going to be that community for us? Who's going to be our social support system as we go through this journey? Because if we have that, no matter what we end up doing for our treatment, and we heard from Dr. Hoodisman all the different ways in which our disease might show up for us, all the different ways our disease might be treated, whether or not we need surgery, maybe we follow a diet, all of those things are part of our individual journey, but also we have to think about our collective journey, right? And that is one of the reasons why I always bring Connie with me to my talks. So I want you to think about Connie as we kind of go through here today, because I'm going to be talking a lot about the role that mental health plays in the management of IBD. It used to be we sort of thought that was a separate problem, right? Even when I started 20-something years ago, people would say, of course they're depressed, they have Crohn's disease. Of course they're depressed, they're anxious, they're going to the bathroom all the time, right? But what we know now is that is no longer acceptable. That does not have to be the case, right? But we also have studied a wide range of reasons why some people get diagnosed with their ulcerative colitis or Crohn's disease and manage to thrive, manage to live meaningful lives, and others struggle more. And that's going to come back to our community and to our coping skills, which I'm hoping I'm going to talk a little bit about today. So why is there an emotional component, right? We saw what happens to your colon. We saw what happens, how you might need surgery, you might need treatment. But if you think about, let's say, the 10 hours a year you're in the doctor's office, maybe you're at an infusion, at the line at the pharmacy, the other 8,700 hours you're spending on your own managing your disease. You're managing your symptoms, you're managing your family life, you're managing your work. Maybe you're trying to spend time on the phone talking to an insurance company. You're doing a lot of things outside of that medical system that can place an emotional burden on you, right? And particularly at times when you don't feel well, the last thing you want to do when you're tired and you're having trouble getting out of bed is to go and do something that is not pleasant, right? Get on the call with the insurance company. You have to, take your kids on a camping trip, right? You're doing things all the time that you don't feel well enough to do, and that is an emotional burden. And that's true of everybody, right? That doesn't mean you have a mental health disorder. That doesn't mean you're at risk for developing depression or anxiety. That's just meaning you're being honest that you have a lot of demands and your emotional, the impact that this disease can have on you is very significant. I always talk about, on your cell phones, right? You have that app always tracking your location, always draining your battery, right? There's always something you have to remember. I'm out at a restaurant. Can I eat this? Can I not? What am I doing tomorrow? If I do eat this, am I going to still feel well enough? What about, I'm at this restaurant. Mindy mentioned, having to use the restroom. You go in, and some people say they have to go in and get their, guilty cookie at the restaurant because they feel bad for having, stunk up the bathroom. All of these things just sort of take away from your day-to-day enjoyment of your quality of life. And again, that's just because you are a person, or your family member is a person living with a chronic condition. Once you are diagnosed, the lens through which you see the world is different. There are many symptoms, and we heard from both Dr. Hudesman and Dr. Rosen that, there's not always a correct match between what's going on inside your body and what you're feeling physically. And so many of our patients, even when their disease is in remission, may have abdominal pain. They may have cramping. They may not have bloody diarrhea, but they may have urgency anyways, right? They may continue to experience symptoms, and this can be particularly frustrating because your doctor may say, "You're doing great on your medication. I looked at your colonoscopy and it looked perfectly pink." But yet you're struggling, you're feeling pain, you're feeling fatigued. Maybe your sleep is disrupted, right? It's getting harder and harder to fall asleep because you're so tense from the day, or you're getting woken up. We know from our research that IBD patients often will have disrupted sleep about 6 to 8 weeks before they develop a disease flare. So it's even that tied to your inflammation in your Crohn's or ulcerative colitis. We know that the other big component to living with a Crohn's or colitis is the change in the way you think about your body, right? And so we know that whether if you take prednisone, you might get moon face, you may gain weight, you may find it hard to control your appearance, you may lose your hair, right? There are different examples where things that you normally would think of something that you can control, you sort of lose control of those aspects of your life. Again, there's nothing wrong with you mentally. This is your reaction to living with a body that may not be working for you the way it used to, right? And coming to kind of grips with that. We also know that having a chronic illness can affect people financially, right? Things cost more. Maybe you have co-pays with your insurance. Maybe you own your own business and you have to miss some work days because of that. Maybe people are relying on you for things, and now because of your health, you're not able to do all the work that you used to be able to do, right? Maybe physical labor is hard. Maybe that abdominal pain. Maybe you've had a surgery. Maybe you have an ostomy or a stoma or something else that keeps you from being able to lift something beyond a certain weight, right? Again, these are all adjustments that people will have to make as a result of their IBD. Now, I know I'm painting a bleak picture of all the terrible things that you have to adjust to, but one of the beauties of having these conditions there can be emotional healing. We talked about treat to target, right? How do we treat to that physical healing? How do we make sure your colon looks nice and pink and there's no inflammation and your CRP levels are normalized? But how can we also look at emotional healing? Not just the absence of concerns, because nobody's going to have that, but the presence of resilience, the presence of community, the presence of people in your life that maybe you are connected to because you've been diagnosed with this condition, right? And at Mount Sinai, where I work in the IBD Center, we operate under something called the Resilience 5. And that is 5 characteristics that we really think that are critical to somebody's ability to adjust to this diagnosis of IBD. And our job, I'm a health psychologist, my job is to apply behavioral principles to medical conditions, right, as a health psychologist. And we find that there's sort of 5 characteristics that we could either teach people or they already have in spades. And when they have that, all these other emotional burdens that everyone with this disease can have over time, over their lifespan, they can figure it out, they can manage. The first one is acceptance of your disease, right? Acceptance of that diagnosis. And I always tell my patients, you do not have to approve of your diagnosis, right? You don't have to say, oh, I'm so glad this happened to me, right? This was a good thing. It made me slow down. It gave me empathy for others. You might think that, but you don't have to, right? But you do have to accept that this has happened to you. You have to reconcile, this happened to me, and I have to move forward in my life, whether or not I approve of it, right? That is really critical to everything that Dr. Hoodisman is talking about. That will affect whether or not you try a new medication, whether you are brave enough to try to come off your steroids and try a new treatment. That may change whether or not you decide to go for a surgery or get pregnant while you're, when you have a disease. All of those things come down to that acceptance of bad things happen to good people, and I can move on despite that, even if I don't approve, even if I didn't want this to happen to me. The second is what we call optimism. Dr. Rosen was talking about this. This is the positive mindset, right? So this is the idea. There's 3 components. The first is that things are not personal, right? This didn't happen to me because I'm a bad person. This didn't happen to me because I, smoke cigarettes, or I didn't do enough exercise, or maybe I should have, studied a little harder at school. The second is this is not permanent, right? Just because I have this chronic condition doesn't mean that the way I feel today is permanent. It doesn't mean that I'll always feel this way, that things will never get better, that I'll never get treated, that I'll never be able to get married, I'll never be able to have a child. That just means right now things are tough, but they're not permanent. And then the last thing is pervasive. So this is the other component of optimism, which is pervasiveness, meaning even if I have a health condition, that doesn't mean that every other thing I do in my life is of no value, right? Just because I have a chronic medical condition doesn't mean I can't parent, doesn't mean I can't study, doesn't mean I can't work, right? It just means that I have a health condition. It's one component of my life. So that's number 2, is the optimism, personal, pervasive, and permanent. The third is self-confidence. So that is what you're doing here tonight. If you are afflicted, and if you're a caregiver, this applies to you too. The self-confidence of, I found a doctor I liked. I know how to take my medicine. I have people at Mount Sinai, we have to teach them how to swallow pills. We have to teach them how to self-inject. We have to teach them how to maybe eat a meal more slowly, right? There's skills involved in this. And so we want to build your confidence in that area. The fourth is what we call self-regulation. We're going to talk a lot about that when I get into the brain-gut connection. But self-regulation means, can I do something hard and keep myself comfortable and calm? Can I face my fears? Can I do something that I never thought I could do, but if I take a couple deep breaths, if I ask for my community for support, can I go ahead and engage in it? And that's what we really want you to be able to do. This is hard. This is why there are psychologists. This is why there are community groups. This is why there are support groups. This is why there are doctors to help you do the hard things despite having this condition. And then the last one, or the fourth one, is the fifth one, the last one, is what I already talked about with Connie here, which is your social support system. And if you want, you can flip over your page of mine that I had handed out, because I just wanted to talk briefly about what we mean by your support system, right? Because we can have negative support systems. I think Mendy gave a couple examples there of someone saying, you're still on those poisonous drugs, you're not going to make it much longer, right? Or, boy, have you tried this, this herbal supplement? That really is a better option for you. We don't need that kind of support. That's not what the tamarins were doing in their cages, right? We want the support that is going to help us adjust, who's going to help us hit our Resilience 5. So when we break down social support, we do that there's 3 different types. And no one person is going to meet all of your social support needs, right? Sorry, if you are a spouse, if you are a parent, you will not be the sole support system for your afflicted family member. If you are an afflicted family member, your spouse or parent or sibling is not going to meet all of your needs. The first type of need we all have to manage this condition is what we call practical support. It's just like it sounds. Who's going to drive you to your appointments? Who's going to take you to your colonoscopy and drive you home? Who's going to come help you with your chores if you're sick, if you're at the doctor, if you're stuck in traffic because you went down for your infusion and you can't get back to pick up your kids from school? Who covers your shift at work if you're self-employed when you're sick? And then maybe who helps you financially, who offers to sort of spot you some money to pay for that extra prescription or that copay, or maybe you need food or clothing or other types of needs when you're out of work because of your disease. So we all need somebody who can provide practical support. And actually on the sheet, I have you thinking about this, so when you go home and think a little bit more, you can write down the name of that person, right? Who's that person that you can use for practical support? Then you have informational support. So informational support is what you're doing here. We're learning about your condition. You're learning about maybe what's worked for somebody else. Maybe you're talking to another person who's gone through a similar experience, somebody who's just recently had a baby. You're talking to them about what it was like being pregnant with their disease. This is where you kind of get information. This person doesn't have to be your best friend. This person doesn't have to know your whole life story. This person doesn't even have to have met your spouse or your kids. This is just somebody that can give you information when you need it, that can tell you about their experience that relates to you, and allows you to kind of know more, going back to that self-confidence. I know more about my condition. I feel more empowered, therefore I can do it. And that can even include your doctors, that can include your dietitians, that can include your psychologists. All those people can provide informational support. And then the last type of support is emotional support and companionship. So that is harder to find, right? That is the person who doesn't need to solve your problem, that just wants to listen, right? That just says, I know it's really hard. Let me give you a hug. Let me buy you a favorite non-baked good for you. That's the person that's going to give you that empathy. They could be local. They can be far away from you. They can be people who, offer their love and support and kind words. They can be people who pray for you. These are people that can distract you when you're sick. They can celebrate your successes. So you also want to be checking in on, if I have social support that's emotionally, are they only there for the drama? Do they want as my kids say, spill the tea? Or do they actually want to be there and have empathy for you? For many people, that can even include a pet, right? So a pet is somebody that could provide you some of that companionship when you get home. They're happy to see you. I also have on here, just FYI, that there is professional mental health support, obviously, that can help fill some of that both emotional support, informational support, less of the practical support, and also for mental health crisis support if you were to find yourself really feeling, which is not, all that uncommon at times to say, life has gotten so hard, not sure, I would be so disappointed if I didn't wake up tomorrow, right? And that's okay. That's a normal response to pain and suffering and difficulty. That doesn't mean that there's something wrong with you mentally. That's a symptom, just like diarrhea is a symptom of ulcerative colitis and Crohn's disease. Sometimes having thoughts of, I just want life to kind of take me away and I don't want to have to deal with this anymore, can be a symptom of suffering from your Crohn's or ulcerative colitis. And I really want to encourage people not to be afraid to reach out for those reasons as well. If we go back to our other page, I'm just going to start to talk a little bit about, so in addition, I gave you sort of the examples of the Resilience 5, and that this is all for people who are diagnosed, who have build resilience, learn the skills that they need, acknowledge that this is an emotional journey, and it has nothing to do with whether you have a mental health condition. However, we also know that a pretty large subset of people living with these conditions do eventually go on to develop something like depression, something like anxiety. And that's because the mind and the body are very much connected. In depression, for example, we're talking about symptoms like low mood, loss of interest in things that maybe you used to find enjoyable, poor concentration, poor sleep, feeling like you're a burden to your friends or family, feeling that life is not worth living, making it harder to make decisions, feeling fatigued or low energy, right? Those are all symptoms that there's something beyond just your coping with IBD that might have set in a little bit. And that can be for a variety of reasons. That can be coping, that can be lack of social support. It can also be inflammation, because guess what? When we were, before we had all of the modern medicines that we have, the body knew enough that when it was inflamed, that it shouldn't get out of bed. It should lay there. It should take care of itself. It should rest. It's only in modern society that we have to actually get up and go to work anyways, right? It's the only reason that we have to kind of, fake it when we don't feel well. And that inflammation is in the brain as well as in the gut. In fact, there are even studies looking at Remicade, infliximab, one of the TNF medications that is used for Crohn's and colitis, can be used, regardless of whether you have an IBD, to treat people with chronic depression. That's how connected inflammation and depression can be in the brain, and how relevant it is to having IBD. And in fact, we would even, at least in my circles, in the psych circles, in the gastropsychology world, we even talk about depression as an extraintestinal manifestation of IBD. So it's not even a separate comorbidity, but it is actually part of it, just like eye sores or joint pain or skin, right? So depression is common. 1 in 4 people will experience depressive symptoms that I just mentioned in the context of their IBD. 30% of people, 1 in 3, will have anxiety. And of course, because like I said, it's a spectrum. Everyone's going to have some anxiety if you're running to the bathroom, when you're newly diagnosed, worry. Worry is actually helpful. If I didn't worry about getting here on time, I might not have pre-planned my Uber ride, right? That was helpful worry. I had a thought of, when do I have to be there? What should I do about it? Okay, I'm going to solve the problem. I worried, I solved it, now I can drop it. But we could also have worry about things that don't have a solution, like having a chronic illness, like being sick. That might take us a little longer. And that's when we start to see a little bit more of that feelings of being down or feeling like you need a little bit more support. We also see 10% of people go on to develop disordered eating. Not surprising, right? Every time I eat, I got sick. Before I was diagnosed in particular, I lost a bunch of weight. Everyone said I looked good, so I wanted to keep going with that. Food makes me sick. I don't know what to eat. I get confused. Those are all precursors sometimes to develop eating disorders and disordered eating, and we're only beginning to scratch the surface on the prevalence of that in the IBD community. And then last of the actual psychological disorders, we have medical trauma, right? And that can be, unfortunately, imposed by the medical system. It can be imposed by procedures that have gone wrong. It can be imposed by going to the doctor over and over again saying there's something wrong with me, and then finding out after years that there actually was something wrong with you and they were telling you that it wasn't, right? All of that to say that that trauma you carry with you may affect outcomes. It may make you less likely to sign up for your colonoscopy. It may make you more hesitant to try a new medication. It may make you less likely to trust your doctor or your care team. And it can make you also more sensitive to the little things that people say. So if you've been highly traumatized by something in your medical care, the next time someone brings up, oh, have you tried this? You're going to feel much more profoundly upset about it because of that history of trauma. So I always like to bring that up, that 1 in 3 people will experience medical trauma too. And again, going back to the Resilience 5, when you have those, all of those things can be improved. And then lastly, and I mentioned types of anxiety, but lastly, I just wanted to sort of end with one of the other key focus areas of health psychologists. And I know NYU has integrated health psychology, Mount Sinai has integrated health psychology, and what we really tend to focus on there is that brain-gut connection. It is even when you are in remission, you may be experiencing pain, bowel urgency, worry about having a bowel accident, right? You may be experiencing extreme fatigue or worry or anxiety, not about world peace, but about your bowels, right? And that's where we can kind of come in and say, okay, there are some strategies here when you're at the grocery store or the deli and you need to go to the bathroom. Maybe you leave your grocery cart in the aisle and run to find the employee-only bathroom, right? What can you do? Right? And we know that the brain is connected to the gut, and there are strategies that you can learn, not to take away those very real symptoms, but to make it a little more comfortable. So for example, diaphragmatic breathing, belly breathing, deep breathing, 4 seconds inhale, 6 seconds exhale is a strategy to turn off your sympathetic nervous system and allow your gut to calm down. Right? Because when you're in a fight or flight situation, all the blood flow is going out to your arms and your legs. It's not going to your gut. You're not stopping to eat or take a sip of soda when you're in an emergency, right? You're in fight or flight mode. And the more you're in that mode, the more likely you are when the emergency is over for blood to rush back to your gut, dump it out, diarrhea. I also tell patients that have constipation, sometimes you're the ones that are like, how do I know that saber-toothed tiger is not coming back around the mountain one more time? I think I'm going to hold on to my stress, right? But we know that the more you have that sympathetic nervous system arousal, that fight or flight arousal, the number of times you flip your switch during the day with something that stresses you out, something your kids did, traffic, work, the general public interacting with, all of those things cause you to flip your switch. And if you think about all the extra effort your gut, all the hits your gut takes on a day-to-day basis from just living in society, you have to be more proactive than the average citizen as somebody's afflicted with this condition to manage that aspect of the stress. And that's where I really encourage you to think about what brings down your sympathetic arousal, what tells you that you are in a safe place. There is no saber-toothed tiger chasing you. There is no emergency. It may feel like that, but really, for the most part, you're safe. 4 seconds in, 6 seconds out is probably the quickest anecdote, but any other types of things, if you like to meditate, if you like to do things that physically relax you, if you like to exercise, any of those things can really be of help. So I want to leave plenty of time for Q&A here, so I just wanted to briefly just say thank you, and I know that this is a tough topic. You're not alone. You have a community. Hopefully, maybe you've even identified other community members. Remember our friend Connie. They are key. Community is key to you getting through this journey, and hopefully you can find that in each other.
Thank you, Dr. Kiefer. Thank you so much. Now we'd like to invite our panel, all three doctors, to come up on the stage here. We were testing out the anxiety during the speech with some hunking outside. I had my friend doing some hunking. I think it was good. Who was paying attention to the hunking and not paying attention to Dr. Kiefer? You have more anxiety that has to be addressed. Now, you can ask a question. Anonymously. There's a QR code inside your booklet. You could just snap it, and in your folder, there's a QR code, and you can ask the questions. Some of you already have asked questions, so I'm going to just start off right here. First of all, thank you so much for coming. Thank you very much for taking your time off, busy time. I feel bad for your patients tomorrow. Might be a little fatigued. All right, the first question is there a big difference between getting a general gastroenterologist or one that specializes in Crohn's? Would you be able to recommend a doctor for Crohn's? You see, okay, which hospital? Okay, so let's just focus on specializing in gastroenterology and Crohn's versus just a regular GI.
Yeah, so I think that's a great question and extremely important. Obviously, I'm biased, but I think you definitely should see a specialist in Crohn's and ulcerative colitis. And you just heard from Dr. Kiefer all these other nuances, right, that if you're seeing a general GI, they're not even talking or addressing about that for the most part, right? So, and the good thing, the second part is most major institutions in New York City have an inflammatory bowel disease center, right? So, NYU, Sinai, Cornell, Columbia, there's good doctors throughout the city. You have to find what works best for you, but I definitely recommend it. Now, I do have a lot of patients that have their general GI that they love. They've been taking care of them forever, and then we could work with that doctor. But you should see a IBD specialist at least once. Yes.
All right, thank you very much. Anything to add, Dr. Rosen?
Nope.
No? Okay. All righty. Next question, and if anyone has a question from the audience, you feel free to raise your hand. If you're old school, non-QR code, we do that also. We're cool with that. Any questions before we? Okay. Okay, we're going to keep it anonymous. I get it. Shame is a big part of this. Shame is a big part. Let's see here. Is the risk of surgery not worse than no surgery?
So I think there's, I talked a little bit earlier about using surgery early, but surgery could be used at any point. And really, when you're evaluating a patient, exactly sort of the question that was asked is, what's the risk? What's that long-term outcome if you stay on medication, if you stay on diet versus going to surgery? And if we think, right, myself and the patient think surgery is that best next step for you where you could have the best quality of life Again, that's a key part of it. Yes, you're going to have surgery those first 4 to 6 weeks. You'll be in the hospital for 5 days, give or take. You're recovering for that month. But that's, 6 weeks in your entire life, right? And if that's going to improve your quality of life afterwards, that's very important. Now, a lot of other issues come up, right? Do you have an ostomy? Do you have a temporary bag? Are you going to be able to hold your children? What are other people going to think? And I think that's where it's working with people like Dr. Kiefer, where everybody, at NYU, before they go to surgery, we try to have them see our nutritionist, our psychologist beforehand, right, to address all of those issues, because the last thing we want is to put them through surgery and their quality of life worsens.
Thank you very much. Dr. Rosen, what percentage of your patients have children who develop IBD or other autoimmune diseases? Are there any preventative measures that a parent with IBD can take to ensure their child's health?
The one thing that worries me and that we didn't talk about tonight is the biome. The billions or trillions of bacteria, good fungi, good viruses that live in our system. A general caveat is to stay away from antibiotics when one doesn't need them. For many years, coming out of the post-war era when we discovered antibiotics, doctors had a knee-jerk response to anybody with a cold or a cough and what it's so-called sinusitis, otitis, all of the other illnesses that are probably not antibiotic illnesses, to prescribe antibiotics. And if there is one caveat that I want to ask everybody to bear in mind, don't beg your doctor for antibiotics, please. A lot of the time, they're not necessary, and my sense is that this wholesale disruption of the biome has a lot to do with what we're looking at today in terms of many of the autoimmune and other illnesses that we are seeing. So don't beg for an antibiotic, and if your doctor says he doesn't think an antibiotic is necessary, that's usually good advice. Antibiotics are wonderful drugs when used in the right instance, and terrible drugs when overused.
I agree completely. And just to add one more thing, and if your child has certain symptoms, sometimes I feel like people avoid bringing your child to the doctor. They think they can get a colonoscopy, but certain things to just be aware. If your child's symptoms last more than a month, if they're falling off the growth curve, right? Those are the things where you're like, okay, maybe I should bring them in. And some simple blood work and stool, and I know it's not as simple in a child, could give us a lot of information doing a little ultrasound without doing anything invasive. So I think if you see that at all, you should definitely bring your child to the doctor.
This is from a parent. Dr. Kiefer, do you recommend children with IBD have a therapist or wait for an emotional concern when it shows up?
Oh, that's a great question. So I don't think it's necessary to, sign your kid up for therapy just because they have an IBD. I think you have to think about what the message is, right? I do think that there are certain kids that maybe are coming, listen, when you get diagnosed with IBD, you've already lived some of your life, right? So things may have already happened to you. It may not just be the IBD that you're dealing with. Maybe you have attention deficit issues. Maybe you've had some you've had other types of trauma. Maybe you have some learning difficulties, and this is just like one more thing that you have to deal with. And in that case, I think it's helpful to be proactive, just like we are with disease management, being proactive and saying, let me just get an evaluation. It does not mean that my kid is not coping, but why not check it out, just like you would with a medical doctor. I think you want to look for some red flags, though. The child's not sleeping, eating, not wanting to talk about it ever, including with his or her family. I think those are all sort of signs that maybe they're not accepting, or that their mindset, that they're scared. Maybe they've went on and read about it or learned about it in ways that you didn't know. Those are all opportunities for a psychologist to kind of to step in. But again, when I talk about psychologists, I'm talking about a health psychologist in many cases, right, where you're really assessing how is your child handling the diagnosis. The other thing that we see people for is procedures, right? So instead of the parent chasing the kid around the infusion center or trying to get the blood drawn, right, we can teach some strategies to build that confidence that they can do those things. It's good for everybody, the parents and the kids. So I would say that there's some, you don't certainly need to do it for everybody, but think about it proactively.
I got two people asking this question for everybody, whoever wants to answer this. What about psychedelics?
Oh, boy.
Jumped quickly, too.
Ooh. No, I don't think psychedelics have any role to play in the management of inflammatory bowel disease. I think psychedelics may have an important role to play in certain psychiatric illnesses. I think psychedelics, unfortunately, because of the governmental restrictions on psychedelics, the science is way, way behind the street, and the street is dangerous right now.
And then maybe just to add about marijuana, since that gets asked about a lot and used a lot, and there's been some studies in press, right? So bottom line, marijuana is not healing the intestine. It's not making the inflammation go away. But in certain cases, it can improve, right, the quality of somebody's life, if they've had surgery, pain, eating, and so forth. So I think in certain situations, it's okay to use, and I'm personally fine with that as long as you're doing that with medical therapy, not alone, right? Again, cigarettes are bad, but in other things you can use.
You got any on you right now?
He's quick.
Yeah.
All right. I have a comment from somebody that actually, I wanted to give him a shout out, Yaeli Drummer, who helped us put together this event 9 years ago. Yeah. Yeah, and I asked him when he walked in there, I asked him, you look a lot better than when I saw you last time. And so he wrote a comment here. He's like, I can attest that surgery was the best decision I made. It was the second best day in my life. Of course, my wedding day was best. Wife is here. It was essential. I'm not supposed to read that part. Okay. It was essential. I reclaimed my life, and I wasn't a failure when it had to happen. So you're not a failure. A lot of people feel like, it's over. Correct?
Yes.
Like I felt that way. Okay. All right. Next question here. Thank you. Dr. Rosen suggested avoiding the bakery. What about home-baked goods with relatively healthy ingredients? Like that challah that you have to have a starter and you got to babysit for like 7 years.
Yeah, so, diet is tough, right? I think, we heard about the biome, microbiome, and we're just not there yet scientifically to put somebody on a specific diet for Crohn's and ulcerative colitis. Very basically, and, whether it's a specific carbohydrate, Crohn's disease exclusion, Mediterranean, it's all the same general things. You want to avoid processed foods. You want to avoid those trans fats. You want to avoid artificial sweeteners, right? So eating a healthy, clean diet. So if you're doing that at home, that's going to be okay, right? That's going to be fine. Really chicken, fish, lean meats, that's all okay, right? Avoid processed, deli meats. Processed meats. Those are probably the worst things you could do, but you also have to be practical, right? If you're a young kid or an adult, you want to grab a couple slices of pizza or you're going to have some wings, that's okay, right? It's not like you're going to do this and all of a sudden your disease is going to explode, right? And you're going to have this huge flare. So you also need to be practical with those recommendations, but I think avoiding those processed foods, those artificial sweeteners are the best things you could do long term. And obviously then you're going to have to get into the nuances depending on that particular person.
There's something I feel about diet which is very important. I think happiness is more important than what you eat. And if your diet is making you crazy, back off. You're more likely to get sick stronger and longer if you're nuts than if you're eating even from the bakery.
Yeah.
We get a standing ovation for that. Yeah. No, that's a really big one. I could attest to that. That I think I got more flare-ups from people driving me crazy and trying to get these diets than the diets actually helped. So, yes, that's huge. We have 2 questions from the audience. Before we do that, while we're still on talking about food, what about probiotics? You mentioned antibiotics, stay away. What about probiotics?
Yeah, so short answer, it's not going to do much for inflammation. There are some caveats, and if you just think about it, right? Again, all of this is important. So when you hear us say this, hear doctors say this, it doesn't mean we don't believe the gut bacteria is important, but none of these are regulated. We have trillions of bacteria, viruses, fungi, and now you're spending however much money on this special probiotic, and you're throwing a few billion of this into the trillion, and hopefully it hits, right? It just doesn't make sense. Saying that, probiotics we do use for symptoms, right? So let's say I have you on whatever therapy, you're doing well, but you still have gas and bloating. That's where probiotics might help. There is a probiotic. It used to be VSL number 3. Now it's called Visbiome. They got into a fight, the owner, so Visbiome's the old VSL number 3, and there is some good data in mild left-sided ulcerative colitis when somebody that doesn't have severe disease that needs biologics, somebody that has surgery. So there are places where we recommend probiotics, but just the concept of, let me go to the store, let me go online and spend all this money on that, I don't recommend that. So symptom-based or in certain patients, Visbiome is what I'd recommend. And if you're talking about other alternative therapies, there are also some nice data in more mild ulcerative colitis with turmeric, where there's some nice data where you get turmeric tab. So I think there's other things you could do, whether that's alone or whether that's in combination with other therapies that can be helpful.
Thank you. Anything else? Okay. We have a question in the back over there.
So I would answer it in a couple ways. And
If you could just include the question for those that
sure.
don't know
So
the men's section.
the question was specifically about Humira, but any biologic, any of these immunosuppressants, how long could you be on it? Is it safe to be on it long term? So short answer, yes, it's safe to be on it long term. I don't think in the future we're going to have all of our patients on this indefinitely, but right now, most of our patients need to stay on therapy. First, if you look at the side effects of these medications, they don't go up over time, right? So the risk is the risk. There's a yearly, so meaning that if you have an infection risk, if you've been on it for 1 year versus 5 years or 10 years, that risk isn't going up, right? There's a very rare side effect, you could argue if it's a real one or not, of lymphoma with your anti-TNFs. That doesn't go up over time with therapy. So the risks don't go up. And if you Remicade or infliximab's our first biologic that was approved in the late 90s, right? So if you look at clinical trials, we have well over 20 years of data, and so they're safe to be on, right? Unfortunately, and I'm going a little off topic, if you look at our current data right now, if you needed to go on a biologic therapy and you're doing well and you're great and you stopped it, within a year to 18 months, about 50% of people will become more active, right? And we're not at the point scientifically yet to say who are the 50, and I think it's probably a little bit higher, but who are the 50% that are going to fly and do great off of therapy, and who are the 50% that are going to get really sick, and then you can't restart. What I'm hopeful for is in the future, we're going to have data that's going to say, hey, are you in the group where we could give you a medication holiday? Maybe everything's reset and we could just focus on diet, and maybe in the future you'll need something, but it won't be continuous, or maybe you'll be in the 50% that needs to stay on it. In the future, we'll have therapies, and we're starting to see this, where we could start and stop, and it's not a big deal. To start and stop a Humira is a big deal. It might not work the second time. So bottom line, it's safe to be on it long term. If you're seeing me now, I'm going to say you're going to be on it for the next 2 years, 3 years, 5 years. Do I think you're going to be on these therapies indefinitely for the rest of your life? No. I don't believe that for the majority.
I'm going to ask a question. The development of antibodies
Yes.
to the drugs that we use, is there an increased rate of the development of antibodies, meaning the drug becomes much less effective when a person has antibodies? Is the development of antibodies to the drugs that we use increased in patients who go on and off their drugs?
Yeah, so great question. So short answer is yes, especially in our Remicade and Humira. So if you stop it and then you restart it, most patients will develop antibodies where you could have a bad reaction. It's not going to work. In some of our newer biologics, when you start and stop, you might not get as high level of antibodies as the older ones, but there's still a high likelihood that they're not going to work the second time. So, what Dr. Rosen's getting at is that starting and stopping, right? And when you look at this data more, you stop, right? And then you restart the same therapy, there's a good percentage of people that it's not going to work anymore, right? And you're going to need to go to something else and then something else. So until we have more data on this, if you're doing well, we're not going to rock the boat. We're going to keep you on it. Now, again, I have some patients that say, Doc, I get it, but I'm going to stop that, and that's okay, and we'll sort of work together. So the other important thing is whether you're starting a therapy, whether you're stopping a therapy, whether you're not going to listen to anything I tell you, at least tell me you're not going to listen to you, so then we could have a strategy for that, right? And I think that's very important as well.
Thank you. You had a question?
Yeah, I have a question, but it's kind of answered.
Oh, okay, cool.
If there's any progress on probiotics.
Progress in probiotics. There's the probiotics, there's the antibiotics, people.
I think the diet's where a lot more research is going, not as diet as a primary therapy, but maybe diet plus a biologic, right? Or coming on. That's where the research is moving. I don't think we're going to see a lot of research in the probiotic space just because it's not regulated, so it's so hard to know what you're really doing there. Right, so things like that.
Once and for all, could we put to rest what should we avoid? Tylenol, Motrin, Advil. What's the best? Keep on bumping into that.
Yeah, so again, also want to be practical. So in general, short answer, you want to avoid all non-steroidals or NSAIDs. So that's Advil, Motrin, Aleve, the high-dose aspirin. Tylenol's okay. Now, saying that, right, it's not like if you take two Motrin, all of a sudden you're going to have a huge flare, right? So I have patients that had an injury, right, and they need to go on a medication like that, and that's probably going to be okay as long as you're on it for a few days, not going to the ortho. On the flip side, I have somebody that goes to an ortho, and they're like, oh, yeah, just take, ibuprofen or naproxen for the next 3 months, right? That's not going to be a good thing. So in general, you need to avoid it, but if you get a bad migraine, and that's the only thing that's going to get you better, it's okay to take a couple, and if it needs to be more than that, then we need to strategize, whether it's an orthopedist, a rheumatologist, a neurologist, to how do we minimize how much you're taking.
So Tylenol is...
Tylenol is good, yes.
I'm going to ask why.
Why?
Yeah.
Yeah, so we don't know, right? I think the first is the earlier thoughts were about intestinal permeability, and that's sort of more of that leaky gut that things can get through. However, if you look at more recent studies with these NSAIDs, it shows that it probably doesn't cause a flare. So I don't think we fully understand it. I think it's probably intestinal permeability would be my best guess, and sort of how long you're on it and dosing, rather than just a few pills here or there.
In my experience, seeing a lot of GIs, I could just tell you the markings of a really good GI is when he says, we don't know why. The ones
Thank you. I say that a lot, so I don't know
Yeah.
if that's good or bad.
Yeah, I've had a lot of very confident ones that didn't really help. Okay. The next question is, the mental health perspective from Dr. Kiefer was so informative, made me consider support needed unrelating to IBD. how do I and then separately, how do I prep a teen for surgery? Is there something that needs to be said? What's the best way to approach that emotionally?
Yeah, so I mean, certainly if it's very focused on something like surgery, I think there's a lot of things you want to be doing. I think, we actually call it prehab, right? So prehabilitation instead of waiting until they have to do rehab after the surgery has not gone well. And, unfortunately, sometimes people just have to have surgery emergently and there's not a time to process, and there's certainly opportunities to do that afterwards and your kid will be okay. However, if we can do anything ahead of time, just about control and autonomy, right? So what would you like your room to look like, right? Do you want to get a special pillowcase? What are you most afraid of? What visitors are you going to want? Let's practice telling people that you're going to be out and why, right? There's a lot you can do on the confidence building side and the self-regulation side that make the surgery go a little bit better. And I would really encourage, especially for a teenager where there's going to be changes to body image, changes to, that they might have to explain to their friends. Maybe they've never disclosed that they have the condition and now they're going to be out for 6 weeks. They need to be able to come up with a story. That's all stuff that I would highly recommend you work on ahead of time.
I'm seeing a few comments here. Thank you about what Dr. Rosen talked about in the shidduch department. Seems to be the biggest fear, and I guess that feeds into the shame and the stigma. So maybe you could alleviate some pressure there, or I'm not sure what the questionnaire wants, but
one has to be honest. Clearly, we want to make shidduchim. Clearly, we want our children to be married and to live normal, happy lives and have children themselves. But at the same time, there needs to be a modicum of honesty. It's very interesting because when you get the question from one side of this shidduch, they expect absolute clear honesty concerning the other side of the shidduch, but they themselves may be holding a few cards in their back pocket. So it's a question of how to spin it. First of all, and a lot of people know me in the neighborhood, so you should know when a question comes to me concerning a shidduch, the first sentence out of my mouth is, don't tell me a name, because if you tell me a name, the discussion ends right there. Talk to me about a condition. I can talk to you about conditions, but not people, unless the other party has given permission for me to talk. And then my job is actually to make the shidduch, not to break the shidduch. So it's how to spin it. And be honest at the same time. I can't say much more than that. I try and spin it right and tell people that there are a lot of people who live very happy, normal lives with inflammatory bowel disease. At the same time, it's a peckle.
Yeah, I'd just like to add, from being around a lot of people in the community with IBD, I think we're special. So I think we're on the, we might be on the clearance rack, but we're like the good stuff that you find on the clearance rack. That's how I put it. And let me just tell you that if you have a bad shidduch without IBD, the person will spend more time in the bathroom.
Right.
You mentioned the danger of smoking. Is vaping the same danger?
We don't have as much data, but yes.
Short answer.
Yeah.
Okay. No vaping. Is there a productive way to stay current with potential new treatments?
Yes, I think there's a couple of resources that I'd recommend. So you have the Crohn's Colitis Foundation. They have all of the treatments on their website, and little summaries about them. And then there's something called the ACG. So that's the American College of Gastroenterology, ACG, and the AGA is the American Gastro Association, and they put out guidelines, and they have like little summaries with tables that you could sort of look at on what all the medications are currently approved, what they generally recommend. So I think those are some good ways. So I would look on the Crohn's Colitis Foundation and then just the GI societies. And then I would speak to your physician because a lot of times on those, both on the website and the societies, they're going to give you a general overview, but you're not going to be able to get detailed information.
Okay, another one. Talking about treating to target and achieving remission, does that refer to all symptoms, not just the gut-related digestive issues? Meaning, will Remicade be able to treat the actual joint pain associated with UC?
Yes, and I think the initial discussion is, right, what symptoms do you have? What do we think is driven by UC and inflammation or not, right? So people could have joint pains that are not related to inflammation, right? People could have fatigue that's not related to inflammation, and they could have fatigue that is, right? So I think you want to set the stage when we start you on therapy. If those symptoms are related to inflammation, like joint pains, like fatigue, yes, that should improve. Now, does it get 100% better, or does it get 70 or 80% better? And if it doesn't get all the way there and you're healed on the inside, that's when we need to start working with our colleagues, thinking about other things that are driving those symptoms. Because again, our goal, when we're saying remission, it's healing, but also getting your quality of life back to where it should be, right? And maybe that's done 100% with the medication I'm prescribing, or maybe it's only getting the medication will get you 60, 70% there. And you're going to need some of the other things we heard about from Dr. Kiever, Dr. Rosen talking about exercise or some other factors as well.
I heard of an experimental stem cell treatment in Israel. My friend got it to treat fistulas. Is it available in the U.S.? Where is most reliable to be treated? What's your opinion on it?
Yeah, so stem cells. So just to get technical, some people with Crohn's disease have something called perianal Crohn's. So you could have severe inflammation in that anal area where you get an abscess or things swell up where you can't even sit down here comfortably. And that's one of the most difficult things to treat for physicians. Also, our therapies don't work as well as they do if you don't have that. So this is a big unmet need. So we have that's where we're using a lot of our infliximab or Remicade, our Rinvoq. Now, stem cells has some mixed data. It's approved in Europe to do, and the European data looks good. And if you look at our US data that did a large clinical trial with this, that it showed that there was no difference than placebo. Saying that, I do think stem cells will have a role, and I think it's more of a technical procedure in that perianal area. So short answer is I would recommend it in a clinical trial in the U.S. because there are clinical trials that are going. And if you're going outside the country, you need to talk to your physician because some of these places are not doing it the right way. There are risks of blood clots with these, so this isn't without risk. So yes, I have some patients that'll go to Europe in certain places, and that's okay as long as it's a place that I know if there's no clinical trial that's open. Hopefully we'll have it available, but right now with the more recent clinical data, that seems to be delayed.
Okay, we have a couple more questions, but we promise we'll be out by 10:30. So I just want to take care of some housekeeping here, and if you're able to stay for a few more minutes to answer the questions, that would be great. First of all, I'd like to thank everyone that made this possible, and big thank you to Esther Begun. Thank you. Thank you very much. Put in a lot of work. Shayna Schmidt. I'd like to thank my wife, Shalamis, as part of the Colon Angels. I think they need a new name. I'd like to thank my daughter, Hinda Pellin, and her friends for setting up, and everyone else's family to help setting up. And also, while we're here, I'd also like to present you with a token of appreciation for coming out here by giving you this is an amazing coffee table book. This is one's for Dr. Rosen. Thank you very much, Dr. Rosen. Dr. Hudesman, here we go. Thank you.
Thank you.
Exercise is one of the best things for mental health. We learned that. So lifting this book, yes. No, it's an amazing book. Yeah.
Thank you.
Thank you.
Also, there is a feedback form. Yes, we are starting this Crown Heights Crohn's and Colitis. This is a new thing, so we're getting off the ground. We have support. We want to see what you enjoyed, what you're looking for, so that we can help support the community. What else did I miss? Anything else? Any other housekeeping? There's food in the back, which you cannot eat. I wanted to just put like nuts and popcorn and a bunch of stuff, and like we put it out there. Yeah, we can see who has a flare up and who doesn't by what they eat. Oh, also we'd like to thank our sponsors, Anonymous, you know who you are. Thank you so much, Benzies, and the rest of everyone. The rest of everyone else. The slide changed. We'll get back to... Oh, there we go. NYU Langone Health, COL Live, Chaim bringing the Chai into the Haim, and G. Chayane Greenbaum. Thank you very much. The beautiful flowers. Thanks a lot. And then we'll just... Thank you so much. Okay. And I'd like to give myself a pat on the back for coming out here tonight, you know? Yes, thank you. Yeah, thank you. It wasn't easy, you know what I'm saying? But we got to get out of the cage, you know? Community is important. All right, last couple questions here. This one is, how common is eczema with Crohn's? How come?
You could see other, we talked a little bit about family history. Sometimes we might not see Crohn's or ulcerative colitis in the family, but you could see other immune-mediated diseases. One of them is eczema. So we do see that in families, and we also do see that in patients. Skin manifestation, so eczema, psoriasis, probably anywhere from about 3 to 7% of our patients will have that. Just one other comment, sometimes our therapies can cause eczema and psoriasis, even though it's used to treat it. So again, another plug to seeing an IBD specialist somewhere, you need to be thoughtful when you're talking about all these different symptoms, right? Is it just a separate disease that you have? Is it part of your IBD? Is it a side effect of the medication? And how do you navigate that?
All right, thank you. By the way, you guys are welcome to leave, or you can stay just for...
We're not in captivity.
Thank you. All right, I'm just trying to get, because people took their time to write their questions here. I'm trying not to get into the too specific questions. There are some that are really, really specific, and I think you should ask your doctor about that. I have many symptoms. Thank God I did tests, etc. I believe it's all anxiety, stress induced. Can constant issues cause IBD over time?
So I would say that stress never helps anything, right? Not that we should avoid stress, but that when we have a lot of it, it can certainly exacerbate things for the same reason that I was saying, with the brain and the gut being really connected. However, I am very reluctant to ever suggest that stress would cause an inflammatory bowel disease. And I think that's really important, because we already blame ourselves for things that we, people will say, oh, well, maybe if I hadn't, worked so hard, or I hadn't, gotten divorced, or if maybe I partied too much in high school. And I really want to make sure that we dispel that, because this is an autoimmune disease, genetics times environment. Stress doesn't help it. Stress is a strategy to get control over it. But just like taking away stress isn't going to cure it, stress does not cause IBD.
Yeah, and I would just sort of, probably listening to you, take a positive spin, right? So if everything looks great on the inside, you should be very optimistic and positive. It doesn't mean we're done working to get you to feel as good as it looks on the inside, but that's a very positive thing, right? So you're healed, and now we could sort of take that part out of the picture and sort of what are your symptoms that are driving it, and let's sort of be thoughtful about that and how do we address it. And sometimes that could be a little more difficult because we're not seeing that inflammation. But again, that's a very positive thing if you're healed on the inside.
Any tips on dealing with fatigue and slowing down in a city that never sleeps?
We don't suffer from that.
I was gonna say, if somebody could tell me. Fatigue is tough, right? So fatigue could be caused by many different things, right? So just simple things off the bat. If there's inflammation, you could be fatigued, so let's treat the inflammation. Low vitamin levels, so making sure you're getting your D, your B12, are you anemic, checked. That's easy things we could check off. Then there's the fatigue that comes with just having chronic disease, right? There's the fatigue that comes with that stress and anxiety, and that's not as easy to treat. There are some interesting studies that have been looking at sort of high-dose vitamins, thiamines, things like that. I'm curious to see how that goes. Lori, Dr. Giver mentioned about sleep, right? That's a big part of it. So again, I think usually the way to approach it is sort of check off the easy things, right? Are your vitamin levels okay? Is the inflammation well controlled? And if you're still having fatigue, that's when you're going to, again, need to be more thoughtful. Is it a stress anxiety factor? Something going on with the personal life? Is it something about sleeping? And start working towards sort of figuring that out.
Right, and I think that one of the strategies for managing fatigue from a behavioral perspective comes down to what I call automation, right? So what in your life can you automate? Maybe you don't want to, but it can help to be a little bit more rigid. So does that mean meal prep on the weekend for the week, so that you're doing one less thing during the week when you're tired? Does that mean things that you normally would take on, but somebody else in your family or your community can do for you? Make a list of the things that are draining your battery and figure out how to recharge. That can be really helpful.
All right. I'll just, I think I'm going to end with this because it's just very loaded. We haven't discussed what causes Crohn's or IBD. What causes it internally? Why can't we stop the body from attacking itself? Doesn't the body know that it's self-destructive? I'm trying to say it in the...
Yeah, so, I tried to touch on that earlier, right? The genetic predisposition, the trigger, and then your body is attacking itself. Unfortunately, we're not at the point, right, for a cure yet. We're not at the point to sort of stop that from happening. But I think something that I would be excited and optimistic about, it's sort of, we're talking about sort of early diagnosis or sort of prevention, right? So can we sort of see, okay, maybe we're catching people earlier on and doing things to help prevent that progression. And that doesn't necessarily mean these biologic therapies. So we're starting to see some early research. This is not ready for prime time there yet, but that's what I'm hopeful about in these next 5 years or so, where we're talking about more early detection and preventing complications. And then hopefully down the road we'll get there. But unfortunately, no cure now and in the short term, in the near term future.
All right, and I just like to finish. I want to encourage everyone to come join the support groups. I think that a big part of this is community, like you said, with this, I remember the shame when I was first diagnosed. I didn't even want to ask someone to pick me up for the colonoscopy. So I went in there and they like, who's driving you home? And I was like, my friend's in the car out in the back there. And they're like, we got to make sure that they're here. It's policy. I'm like, yeah, okay. Young men. And I learned the hard way why they have this policy, by the way. when I just fell asleep by the red light and just rolled into traffic into another car. Don't try that, by the way. Don't try to drive home after a colonoscopy. Shame hurts. And I really encourage everyone, there's nothing to be ashamed about. This is something that Hashem has given to us for a reason. We don't know why. The bigger the doctor you have, the bigger he'll say, I don't know why it is, but we're here, we're together, let's embrace it, let's just tackle it. Thank you so much for coming, and don't forget to fill out the form. And one last thing. What?
That was great. Yeah, it was really a nice night.
Oh, upcoming events, you see.
Amazing.
Where is it?
Nice little panel.
Oh, upcoming events in April featuring a health expert. In May, June, breathwork sessions. So there's upcoming events. Check it out here on inside your booklet. Thanks for coming.